There's a moment I hear about constantly in my neurology clinic. You're mid-sentence, reaching for a name. A
I heard
neighbor,
about
a
something that might
grandchild's
concern you.
teacher, someone you've known for years, and it's just gone. Not at the tip of your tongue, just gone. And for a
Oh,
second,
wait, what
your
was it?
heart drops. I want to talk to you about that
Wait,
moment. Because what most people assume is that it's age, that the brain is simply winding down. But what if the fog isn't coming from inside your brain? What if it's coming from your medicine cabinet? Today I want to walk you through 5 medication classes that research has linked to memory loss and cognitive decline. And more importantly, I'll tell you what you can actually do about it. Pill number 1. Anticholinergics. Let's start here, because this is the class with the most consistent, well-studied evidence. And it's also the one most likely to be sitting in your bathroom right now without you realizing it. Anticholinergic is a long word for a simple idea. These are drugs that block a chemical in your brain called acetylcholine. And acetylcholine is critical. It's the neurotransmitter your brain uses to form new memories, to process information, to keep your thinking sharp. Think of your neurons as a busy orchestra. Acetylcholine is the conductor. When you block it, the musicians are all still there, but without that conductor, the performance falls apart. Notes come in at the wrong time. The sound becomes confused. Here's why this matters so much for people over 60. As we age, our natural acetylcholine levels already decline. So when you add a drug that actively blocks what's left, you're not starting from a full tank. You're starting from half a tank and then draining it further. Now, what makes this especially frustrating is that anticholinergic drugs hide in places people never expect. And when I tell you where, most people are genuinely caught off guard. Because these aren't unusual drugs. They're not obscure prescriptions most people never encounter. Diphenhydramine, the active ingredient in Benadryl, Tylenol PM, and ZQuil, is a strong anticholinergic. Oxybutynin, commonly prescribed for bladder control, is another. Older antidepressants like amitriptyline carry a high anticholinergic burden. So does hydroxyzine, which is frequently given for anxiety. I've sat across from patients who thought they were losing their minds. One woman in her early 70s came in convinced she had early Alzheimer's. She was foggy in the mornings. She was losing words mid-conversation. She was frightened. When I reviewed her full medication list, she was taking a sleep aid containing diphenhydramine, a bladder medication, and an antihistamine for seasonal allergies. Each one, on its own, has anticholinergic properties. Together, the cumulative burden on her brain was significant. We worked with her prescribers to find alternatives. Within a few months, her family told me she seemed like herself again. This is what the research supports. A large analysis found that anticholinergic use for 3 months or more was associated with a meaningfully increased risk of dementia. And that risk rises sharply when multiple drugs with anticholinergic properties are taken together. Not added, multiplied. Because the brain doesn't process each drug in isolation, it experiences all of them at once. And this is where I want to be honest with you about the way our healthcare system works. These drugs were never designed for indefinite daily use in older adults. But that's exactly how millions of people end up taking them. Because a prescription gets written, it helps in the short term, and then nobody revisits whether it's still the right choice years later. If you're taking anything with PM in the name, or anything prescribed for sleep, bladder urgency, or older generation allergies, it's worth asking your doctor specifically whether it has anticholinergic properties. there are good alternatives for many of these conditions. Second-generation antihistamines like cetirizine or loratadine don't carry the same brain burden. For bladder issues, mirabegron works through a completely different mechanism and doesn't block acetylcholine at all. This is not about alarm, it's about awareness. Your brain is working hard every day. It deserves a medication list that's working with it, not against it. Now, anticholinergics block a chemical your brain can't afford to lose. But the next drug on this list works differently. It doesn't block anything. It slows everything down. And that distinction matters more than most people realize. Pill number 2. Benzodiazepines. Let me tell you about the most common trap I see in my clinic. A patient comes in struggling with anxiety or insomnia. Their doctor prescribes a benzodiazepine, lorazepam, diazepam, alprazolam, temazepam. Within days, the relief is real. The racing thoughts quiet down. Sleep comes easier. It feels like a solution. And it is, in the short term. That's the honest truth. Benzodiazepines work by enhancing GABA, which is your brain's natural braking system. It slows neural activity down, reduces overstimulation, creates a sense of calm. For acute anxiety or a genuine sleep crisis, there's a legitimate place for these drugs. But here's what happens when weeks turn into months and months turn into years. Think of it this way. Imagine you're trying to record something important, a conversation, a memory, a name you need to hold on to. But the filing room where your brain stores new information is running in slow motion. The drawers are stiff. The lights are dim. That's what chronic benzodiazepine use does to the hippocampus, the brain structure most central to forming and retrieving memories. GABA enhancement doesn't just calm anxiety. Over time, it dampens the very processes your brain needs to consolidate new information. What I see in long-term users is a particular kind of fog. Not dramatic, subtle. Words that used to come easily start taking a beat longer. Following a complex conversation becomes tiring in a way it never used to be. Executive function, the ability to plan, organize, make decisions, gets sluggish. Patients often describe it as feeling like they're thinking through glass. Now, I want to be careful here, because the science on benzodiazepines and dementia causality is genuinely debated. Some studies show a significant association with long-term dementia risk. Others argue that the relationship runs in reverse, that early anxiety and insomnia may themselves be early symptoms of neurodegeneration, meaning the drug didn't cause the problem. It was prescribed because the problem was already quietly beginning. This is called reverse causation, and it's a real methodological challenge in this research. What is not debated is this. Long-term benzodiazepine use causes measurable cognitive impairment. Memory, attention, processing speed, visual learning, these are consistently affected in people who use these drugs over months and years. That much is clear across dozens of studies. And then there's the trap itself. When someone tries to stop a benzodiazepine after long-term use, the brain pushes back hard. Rebound anxiety. Insomnia that feels worse than whatever prompted the prescription in the first place. Sometimes heart palpitations and sweating. The brain has adapted to the presence of the drug, and removing it suddenly creates a genuine withdrawal syndrome. This is why so many people stay on these medications for far longer than their prescribing doctor ever intended. Not because they want to, because stopping feels impossible. If you've been on a benzodiazepine for more than a few months and you're noticing cognitive changes, please don't stop on your own. That can be dangerous. What I'd encourage you to do is have an honest conversation with your doctor about a slow, supervised taper. Gradual dose reduction over weeks or months, done properly, gives the brain time to recalibrate. And the alternative that has the strongest evidence behind it isn't another pill. It's cognitive behavioral therapy for insomnia, known as CBTI. It addresses the underlying sleep patterns directly. In clinical comparisons, it outperforms sleep medication in the long run, without touching your brain chemistry at all. Pill number 3, proton pump inhibitors. Now here's one that surprises people almost every time I bring it up in clinic. Because it's not a brain drug, it's not a sleep drug, it's a stomach drug. And yet, the biology of what it does, quietly, over years, can reach all the way up into your neurons. Proton pump inhibitors. You almost certainly know them by their brand names. Omeprazole, pantoprazole, esomeprazole. These are some of the most commonly prescribed drugs in the world, designed to suppress stomach acid for heartburn, GERD, and acid reflux. And for what they do in the short term, they work well. If you've got active erosive esophagitis or a peptic ulcer, a PPI is genuinely useful medicine. The problem is what happens when short-term becomes indefinite. But here's what most people never consider. Your stomach acid isn't just there to cause problems. It plays a critical role in breaking down food and extracting nutrients, particularly vitamin B12 and magnesium. When you suppress that acid aggressively over a long period of time, your body's ability to absorb those nutrients drops significantly. Think of vitamin B12 as the insulation around your brain's electrical wires. Without enough of it, signals start to short-circuit. You get nerve conduction problems. You get cognitive fog. You get the kind of fatigue and confusion that can look, on the surface, a lot like early cognitive decline. And because B12 deficiency builds slowly and quietly, many people, and even many doctors, don't connect it back to the pill taken every morning for acid reflux. Magnesium matters here too. It's essential for proper nerve signaling and synaptic health. Low magnesium affects how efficiently your neurons fire and communicate. Again, not dramatic at first, just a slow dimming. And here is the Alzheimer's connection I promised. Some studies suggest that PPIs may impair the brain's ability to clear beta amyloid, the toxic protein associated with Alzheimer's disease. The mechanism proposed involves how PPIs interact with certain enzymes involved in amyloid processing. I want to be honest with you. This research is still active, and we don't have definitive proof of causation in humans. But the signal is there, and it's one more reason why long-term PPI use deserves scrutiny. What does the evidence actually show? The picture is mixed, and I think that honesty is important here. A large prospective study found that cumulative PPI use beyond 4 years was associated with a meaningfully higher risk of developing dementia. But another well-designed study in older adults found no significant association at all. The difference, in many cases, comes down to how long someone has been on the drug. Short-term use, a few weeks, a few months, appears to carry much less risk. It's the indefinite, years-long, never revisited prescription that raises concern. And that's exactly the situation millions of seniors are in. They were put on a PPI for a bout of reflux. It helped, and no one ever stopped to ask whether they still needed it. Here's what I want you to take from this section. If you've been on a PPI for more than a year, ask your doctor 2 things. First, do I still need this? Many people can step down to an H2 blocker or manage symptoms with lifestyle changes. Second, Have my B12 and magnesium levels been checked recently? That's a simple blood test. And if those levels are low, that's something we can actually correct. What you've just seen with PPIs is a slow, indirect drain, nutrients quietly depleted over years. The next one on this list is also indirect, but the mechanism is completely different, and so is the way it hides. Pill number 4, sleep aids, Z-drugs. I want to talk about a category of drugs that was specifically designed to be safer than benzodiazepines. That was the selling point when they arrived. Fewer side effects, lower dependence risk, a gentler path to sleep. And compared to the older benzodiazepines, they do have a somewhat different profile. But in my clinic, I've watched long-term use of these medications create a very particular kind of cognitive shadow, and I think more people need to understand why. The drugs I'm talking about are called Z-drugs. Zolpidem, sold as Ambien. Ezopiclone, sold as Lunesta. Zaleplon. These are among the most commonly prescribed sleep medications in older adults. And they do work, in the sense that they help people fall asleep. The problem is what kind of sleep they actually produce. Here's the distinction that matters. There is a difference between being sedated and getting restorative sleep. Deep, slow-wave sleep, the kind your brain genuinely needs, is when your brain runs its nightly maintenance cycle. Think of it as a night shift cleaning crew. While you're in deep sleep, a waste clearance system in your brain activates and flushes out toxic byproducts that accumulate during the day. One of those byproducts is beta amyloid, the same protein we associate with Alzheimer's disease. Your brain is literally clearing out what it doesn't need, resetting for the next day. Z-drugs sedate you, but sedation is not the same as deep sleep. The architecture of your sleep, the cycling through stages your brain needs to do this cleaning work, gets disrupted. So you feel like you slept, but your brain didn't get what it actually needed. Night after night, year after year, the waste accumulates. The cleaning crew showed up, but the lights were off and the doors were locked. A long-term study tracking older adults over 15 years found that frequent sleep medication use, 5 or more times per month, was associated with a significantly elevated dementia risk in regular users. That's not a small exposure, but it's also not an unusual one. In fact, research has found that a substantial portion of sleep aid prescriptions in seniors were written without documented clinical need, which means many people are taking a drug with real cognitive consequences for a problem that was never properly assessed in the first place. I worked with a patient, a retired teacher, sharp man, someone who had always prided himself on his mental acuity, who had been on Zolpidem nightly for nearly 6 years. His wife came with him to the appointment. She described it quietly, carefully, the way spouses do when they're worried but don't want to alarm their partner. He wasn't himself in the mornings. He'd ask the same question twice. He'd seem confused about the day. He thought it was age. She wasn't so sure. We did a slow taper over 3 months, paired with CBTI and some basic sleep hygiene adjustments. Within 2 months of being fully off the medication, his wife sent a note. She said he'd come back. That's not a miracle. That's biology reversing when you remove what was blocking it. If you're taking a sleep aid regularly and you've noticed morning confusion, word-finding difficulty, or a subtle flatness in your thinking, it's worth raising with your doctor. The first step is never to stop abruptly. That can cause rebound insomnia and, with some drugs, withdrawal. The step is to start the conversation and to ask whether what's helping you sleep might be costing your brain something it can't easily recover overnight. Pill number 5, statins. Now I want to handle this one carefully, because statins are the most contested drug on this list, and you deserve the full picture, not a simplified version designed to alarm you. Statins are among the most prescribed drugs in the world. Atorvastatin, simvastatin, rosuvastatin. They lower LDL cholesterol, and for people with cardiovascular disease or significant heart risk, they genuinely save lives. I want to be clear about that before I say anything else.
So where does the cognitive concern come from? And why did the FDA feel strongly enough to add a formal label warning about memory if the large studies don't confirm the risk? That tension is real, and it's worth sitting with before I give you my honest read on it. Your brain is nearly 60% fat, and it relies on cholesterol to build and maintain myelin, the insulating coating around your nerve fibers that allows signals to travel cleanly and quickly. Some researchers have raised the question of whether aggressively lowering cholesterol, particularly with statins that cross the blood-brain barrier, might affect that process in some individuals. Patient reports of brain fog after starting a statin are real and documented. Documented enough that the FDA added a formal label warning about memory in 2012. Some people describe sudden confusion, memory lapses, a feeling of mental slowness, and in many of those cases, the symptoms resolved when the statin was stopped or switched. That's worth taking seriously. But here's where the science gets complicated. Large-scale prospective studies and meta-analyses have not confirmed that statins cause dementia. In fact, several analyses point the other direction entirely, suggesting that long-term statin use, particularly beyond 3 years, may actually reduce dementia risk, possibly through anti-inflammatory effects and improved blood flow to the brain. One major study of nearly 19,000 older adults found no association between statin use and incident dementia or cognitive decline. Another meta-analysis found that statin users had a 14% lower dementia risk than non-users, and that the benefit grew stronger with longer duration of use. So what do you do with that? My honest clinical read is this. Statins are not the villain here, but they're not above scrutiny either. If you started a statin and noticed cognitive changes within the first few months, that's a real observation worth raising with your doctor. It may be the drug, or it may be something else entirely happening at the same time. Don't stop unilaterally, but do have the conversation. There are meaningful differences between statin types. Lipophilic statins like atorvastatin and simvastatin cross the blood-brain barrier more readily than hydrophilic ones like pravastatin or rosuvastatin. Switching types, rather than stopping altogether, may resolve symptoms while preserving your cardiovascular protection. Your cognitive symptoms deserve to be taken seriously, and so does the evidence that these drugs, for most people, are doing more good than harm. So you've now looked at 5 different ways medications can work against your brain. The question is, what to do with that? Here's where to start. Go to your kitchen table. Pull out every pill, every capsule, every supplement, every over-the-counter tablet you take. Put them all in one place. Then bring that collection to your next doctor's appointment and say these exact words. I'd like a full medication review with a focus on cognitive side effects and anticholinergic burden. Pharmacists actually have a name for this. They call it a brown bag review, and many will do one with you directly, separate from your physician visit. It's a practical, underused resource. You don't need to diagnose yourself. You don't need to memorize everything I've said today. You just need to start that conversation. Because what I've seen again and again in my clinic is that drug-induced cognitive impairment, when caught early, is often reversible.
This is not a story about inevitable decline. It's a story about biology, and biology can be changed. If you're not sure where to start, or you have questions about a specific medication you're taking, leave them in the comments below. I read through them, and your question may be exactly what someone else needs to hear answered. But here's what I need you to understand before you close this video. Clearing out medications that work against your brain is a meaningful step, a real one. But it only protects what you have right now. And while you've been reading about these pills, there may already be something else happening inside your brain, quietly, without obvious symptoms, that has nothing to do with what's in your medicine cabinet. There are 5 early warning signs that can appear years before a formal diagnosis. Most people miss them. Not because they're not paying attention, but because these signs don't look the way most people expect. They don't look like forgetting. They look like something else entirely. That's exactly what my next video covers. And if you've just done the work of reviewing your medications, the next logical question isn't, what else should I avoid? It's, how do I know if my brain is already trying to tell me something? The video is right there on your screen. Watch it now, while this is still on your mind. Because the progress you've made today is only as valuable as what you do with it next.